For a warm introduction, and thank you to the organizing committee for this opportunity to have a wonderful debate with my esteemed colleague. So, as requested, each slide will have one history of diabetes photograph, and this was in about 1552 BC, where they thought maybe passing too much urine was a diabetes. So, the debate today is testosterone should be checked and replaced for every diabetes patient. I start with, should we check blood pressure in a diabetic patient? Yes. If the blood pressure is abnormal, should you treat it? Yes. Should we check lipids in a diabetic patient? Yes. If lipids are abnormal, should you treat it? Yes. Should we check proteinuria in a diabetic patient? Yes. If proteinuria is present, should you treat it? Yes. So we are moving from a glycemic point of view to holistic care in diabetes. We're talking about cardiovascular care and benefit, renal care, eye care, neurological care. Then should we not check sexual health with symptoms and testosterone in a diabetic patient? I think we should check it. And if symptomatic and testosterone is low on proper measurement, should you treat it? A resounding yes. My predecessors in this session have already told what hypogonadism is, why it is caused, and generally in studies a total level of below 300 nanogram per deciliter is commonly used to define biochemical testosterone deficiency. But as I said, we combine it with symptoms. So there's a beautiful questionnaire called the Adam questionnaire. And this questionnaire has about 10 points. And if the answers to 1 or 7 questions is positive, this is taken an indicator of a sexual problem. Or if there are 3 questions which you have a yes answer, then it is taken as a problem. So combine this with the symptoms of a patient and the testosterone level of less than 300 properly measured, maybe a couple of times just to make sure that you are not having any fallacies with measurement early in the morning, so that you are confirming testosterone deficiency and then trying to do that. Now, why is male hypogonadism important? Because it constitutes a significant proportion. Close to 40% of men with type 2 diabetes suffer from low testosterone levels, often unrecognized and undertreated. It leads to a lot of metabolic effects as well, in addition to sexual dysfunction, including the increased visceral fat, insulin resistance, and dyslipidemia. The relationship is bidirectional, each one influences the other. So the testosterone replacement therapy, it basically aims to restore normal testosterone level, improving clinical symptoms and metabolic parameters. Recent studies have shown that the testosterone replacement can enhance the insulin sensitivity, reduce body fat, increase lean muscle mass, improve lipid profiles, thus offering significant benefits for diabetes. Obviously, with any therapy, there will be certain potential risks, which include erythrocytosis, cardiovascular events, prostate health issues, and potential for misuse. However, a lot of studies have told that the benefits of treatment far outweigh these potential risks, and whether these risks actually exist, to what extent they exist, we will go through. This again a few graphs showing the prevalence of hypogonadism, especially increasing with age. Effect of sexual function in type 2 diabetes mellitus. With testosterone therapy, you have significant improvement in the IAEF scores. The HOMA-IR improvement with testosterone replacement, and the HbA1c significantly improving with testosterone replacement. Not only that, what we're talking about mortality, this graph clearly shows that low testosterone level predicts increased mortality. Testosterone therapy actually improves survival in men with type 2 diabetes, close to almost being a normal testosterone level. We have a recent Indian study also from Kolkata, from Orissa rather, which actually shows a lot of parameters, your BMI, waist circumference, the sugar, HbA1c, the lipids, all improving post-TRT. I'll quote several studies and then try and see, because the major 2 things are prostate cancer and CV outcomes, which we are afraid to start. So this actually will show that this 2020 study clearly shows that there's additionally no myocardial infarction or strokes in the testosterone treatment group. The impact of testosterone replacement on glycemic control and vascular function. So because we are concerned with cardiovascular health, actually the flow-mediated dilatation is improved by testosterone therapy. Therefore, endothelial function improves, and we know how important endothelium is for cardiovascular health. Similarly, this study again by Yasin et al. Shows that testosterone therapy, the mortality was significantly low with reduced incidence of non-fatal MIs. Treatment of testosterone therapy in type 2 diabetic hypogonadal males, significant metabolic benefits. Similar study, this is a type 4 DM study, which actually showed preventing the progression to diabetes from pre-diabetes. Some people actually reverted to normal sugar, and safety compared to placebo, there was no extra cardiovascular or prostate cancer adverse effects. Recent study from Lancet. This study again used for treatment testosterone use in both type 2 diabetes showed significant metabolic benefits, including lipids which were improved. A lot of bodies also have told that you please test it. 2016, the American Academy of Clinical Endocrinology told that in all men with type 2 tested. ADA 2021 initially said those with symptoms you evaluate. 25 again they said inquire about sexual health. We're not asking them, so we're not testing them. And then there's no conclusive evidence that testosterone supplementation is associated with increased cardiovascular risk. The RSSDA again says that you ask for symptoms and test it, but test it properly in the morning time with a good lab so that you're not getting an improper result and not improperly treating. British Society of Sexual Medicine again says that all type 2 diabetes are probably obese, you test them. You already have had some discussion on different formulations which are available. I won't go into that. Now this is the American Urological Association, which again in last 2024 had given this guideline that you test in diabetes even in the absence of signs or symptoms of deficiency, but you clearly monitor the hemoglobin and the hematocrit values. And they said that there is no risk of prostate cancer, but they said the cardiovascular benefits were not very clear until this landmark trial, that is the TRAVERSE trial, came about. And as you can see in the box below, it clearly states that after a mean treatment of 22 months, the percentage of MIs, stroke or CV related deaths adverse effects was 7% for testosterone versus 7.3 for placebo. So it is not more than placebo. And these were patients with actually high risk cardiovascular disease or a pre-existing cardiovascular disease. So in a very high risk population, this NEGM study clearly showed no risk of high cardiovascular event. So these data confirm that 2-year follow-up, there's nothing problematic in the heart side. Now, we had these earlier studies which gave some problems with cardiovascular outcomes because they were flawed. Each study had some problem which were not designed properly, took into account something like Finkel et al., Basaria et al., you have the Zhu et al., and one more study by Copenhagen et al., which actually had flaws, and I've included the flaws for lack of time. I'm just skipping that, but these studies were the ones which actually, and this figure actually shows how in heart failure itself, testosterone might have significant beneficial effects. Now this is the last month study, 2026, in the World Journal of Men's Health. Now there has been a total shift in understanding of how testosterone influences the prostatic thing. Initially, the 1941 study had said that testosterone means prostate cancer. Now we have realized that that is not simple like that. The level of testosterone, the saturation point beyond which it actually affects the prostate growth, is found a totally different thing. And now we know that there's no direct correlation with high testosterone level and increased cancer growth, and endogenous testosterone variation within the normal range did not influence PSA levels of prostate cancer risk. Different bodies, BSSM, AUA and EUA again said no compelling evidence to suggest TRT increases the risk of developing prostate cancer. We actually move ahead with the safety events also. In carefully treated screen hypogonadal men, it does not increase the prostate cancer. Last 2 minutes will complete that. Not only in that, in those people who are at high risk of prostate cancer also, there is no increased risk. Not only that, somebody who's had a radical prostatectomy for prostate cancer and you still give testosterone therapy, again there is no risk, extra risk which is there. So the summary is that TRT is oncologically safe for hypogonadal men following radical prostatectomy, increasingly supports TRT as a safe and effective option for hypogonadal men. Again I come back. Will you monitor for side effects like hyperkalemia while on ACE inhibitor, ARB, spironolactone? Yes. So similarly, in conclusion, you should test every diabetic patient, asking both the clinical symptoms of sexual dysfunction and check testosterone level appropriately in the morning, 2 samples, to confirm that you are not getting confounded. Then treat it appropriately, but as we do with any other drug, monitor very, very carefully for the side effects which we see. So a devout conviction to thrive is a quiet fire that refuses to dim, an unshakable faith in purpose that turns adversity into acceleration and vision into victory. Thank you.
Thank you, Doctor. Thank you very much. So